I would like to thank Canon Medical Asia for inviting me to have a session on role of SMI and shear wave elastography and attenuation imaging for evaluation of liver pathology. So let's begin with the first modality of the machines is SMI. SMI stands for Superb Microvascular Imaging. This is the microvascular technique for ultrasound. So before we begin that, we have to know that when we use the Doppler color, the conventional system, the signal that have movement and detect with Doppler shift have many background of the information. The major one that we don't want is the noise or clutter or tissue background that have shaking movement, small amount of that. And also we have a signal of true vascular flow. We need this one. So in order to get the eliminate and get the good image, the machine have to eliminate the tissue clutter out. So with this technique, we have to use the Doppler filter or we use the wall filter to eliminate the slow flow. So the information we get, we also eliminate the slow flow out that the machine do not know that it's a noise or just small vascular flow. So the signal that we get significant vascular flow from the artery or vein that we interested in. And for the SMI is another technique that instead of eliminate all of the slow flow out, the filter can filter out only the tissue clutter and can preserve the microvascular information here. So instead of get rid everything that has slow flow, they can preserve the slow flow of the vessel, the small vessel. So the further information of the micro vessels can be found in this technique. This is an example of the microflow. The good one is for the kidney. So if we use SMI for the kidney, we can see the microvascular structure include the interlobar artery and the arcuate artery, and also we can distinguish normal structure including the medulla and the true cortex of the underlying parenchyma. So with the microvascular information detected on SMI, you will get a better visualization of microvascularity, which can represent the normal structure inside the organ that we will see on ultrasound. So for applying to liver imaging, my experience, we use for the three major indications to apply for more in clinical practice. One is I use it for the mass detection. Since if we see normal vascular structure, and if there's a mass or mass effect, the vessels will be distorted or displaced from the normal location. This represents something happened inside the liver or organ that we are studying, either infiltrative, especially in terms of lesion that is isoechogenicity that we cannot see on B mode. If there has mass effect from vascular displacement, this is confirmed to be true lesions. And also to distinguish between true lesions and pseudo lesion, in liver we have problem with focal fat sparing, which is a hypoechoic, but in this area it should not have abnormal vessels. It can have a decreased vascularity but no mass effect. Versus true nodule should have vascular effect, mass effect on vessels, and also abnormal vascularity will give rise to favor the true nodules. The last one is a flow pattern of the SMI. In some publication, there's a characteristic for SMI pattern that could suggest hemangioma and FNH, which I have a case to show you. Let's start with the first case. So this is a patient of 80 years old, come with cirrhosis and for HCC surveillance. So given this situation of cirrhosis, we have to make sure every single area of liver have no mass because the chance of HCC is high. So for B mode, we can detect the cirrhosis, but in my clinical practice, I always use SMI to detect the lesion. If I use SMI and see the normal vascularity like this, I have confident that there's no major infiltrative lesion inside the liver parenchyma. So sometimes we will have a near field artifact obscuring liver, or liver is a very small size. So with this one, we also have more confident that there's no infiltrative lesion, and also we can detect the normal vascularity inside. There's no clot or thrombosis inside the small vessel as well. So in the other case, come for surveillance as well. Patient have come and for screening for HCC, but no evidence of hepatitis B. So with the B mode, we have something subtle on the anterior surface of subcapsular area of segment 4. We don't see much because it is the lesion is iso. It's almost missed the lesion, but the subtle thing is there's a subcapsular retraction here. So in order to make sure what it is, it seems like there's something, but we don't show because it's very iso. So we apply the SMI. SMI in this case, we see the abnormal vascular distortion, displacement around the lesions. Like this. Here. So vessel is displaced away and surrounding the lesion. This is a mass effect. This is obviously a mass if we have information from SMI. Patient undergo to MRI. This is confirmed to be the FNH. It's very huge, like 8 centimeter. And ultrasound at the first place for B mode, it can easily miss on B mode ultrasound. But SMI can detect this one to make sure and then confirm there's a mass and go to further investigation. Also the flow pattern of the nodule and also give more information. The good one, for example, is the hemangiomas. This is the hypoechoic nodule on background of fatty liver. If we see the pattern of rim vascularity with the peripheral nodule enhancement like this on SMI, this is a typical pattern of hemangioma that has been reported on the publications. So this one give us the confidence that we can follow up on ultrasound and no need to be very hurry for CT for confirmations. If there's a pattern like this, I feel comfortable for follow up. And also if the patient is low risk, we can follow up with this with confirmation of the flow pattern like this. This one is also another lesions. The background of a patient is a cirrhosis, have chronic liver disease, and see the hypoechoic lesion near the gallbladder fossa, which is area of common for the focal fat sparing. So we do use SMI to see if we can distinguish between the focal fats or true nodules or not. I have to focus here, area here. So this is a true nodule because it's a rim vascularity, and inside there's a vascularity inside here as well. See again, here there's some vascularity, moving blood here. So this one we consider this is should have to investigate because the background of chronic liver disease, and also inside have a vascularity like this. So we go on. And the lesion have arterial enhancement and venous washout. This is considered typical for small HCCs. So this patient have treatment after that. This is a small HCC that we can detect on SMI. And SMI give more information and prompt treatment to the patient. Let's move to the other case. The other case is also hypoechoic nodule inside the background fatty liver. So we use SMI. We see the pattern of the rim enhanced with central scar spoke wheel pattern like this. This is more favorable for focal nodular hyperplasia. This one, like a star-like central vascularity like this. So in this case, this is a report quite typical for focal nodular hyperplasia, and this one confirmed with the MRI. So they have a homogeneous arterial enhancement and also uptake of the hepatocyte-specific agent like this. So this is the focal nodular hyperplasia. You can see the nice example of the spoke wheel vascularity inside the FNH. So let's move to the second application, which is attenuation imaging or ATI for liver pathology. So attenuation imaging is the application that used to quantify liver steatosis or fatty liver. So it works like this. When the sound beam passes through the liver tissue that have fat, the fat content will attenuate the sound like this curve. The more the sound beam penetrate deeper, and the attenuation will lost. The amplitude of the sound will be lost by inverse square law. So in order to measure the constant to see if how is the property of attenuation, presuming that the more fatty, the attenuation coefficient of the liver will be increased by the severity of the fatty liver. In order to do that, the machine has to adjust other factors including focus. The beam homogeneity should be controlled, and the gain compensation should be controlled as well. When we control everything and readjust to and convert into the slope of the attenuation coefficients, it's gonna be a linear model like this. We use the coefficient of the attenuation to be the constant measure value. The more attenuation coefficient that measure from ATI is the more fatty change correspond to the more fatty infiltration of the liver. There are other modalities that can quantify the fat content inside the liver. The previous one is a control attenuation parameter or CAP. This is the modality inside the FibroScan machine that also use the same technique for sound attenuation to quantify the fat content. The other one is MRI-based proton density fat fraction, which is using MRI Dixon technique to quantify like in phase or post phase and quantify for percent fat inside the liver. MR-PDFF is considered a non-invasive standard for reference in clinical practice. So when we compare ATI and CAP, which is the ultrasound-based technique, we found that for the literature review by Ferrarioli, he found that the ATI has more R-squared correlation to MR-PDFF than CAP value. So with ATI technique, I think it's comparable and correlate with the PDFF more than CAP. Okay, let's see some cases using ATI. This is example of the random patient which has no fatty change on grayscale comparing liver and kidney cortex parenchyma. So when we do the ATI, we just place the green box in the right lobe liver using intercostal approach, and then measure the ROI inside the green box in the center, and then try to avoid the orange here, the orange color here, because it represents the near field artifact that can influence that is a noise just avoid that and then measure the box. The box is fixed, so no need to adjust anything, and then you just measure. So the cutoff for the S1 is the mild fatty change is around 0.6. So this one is 0.56, which is considered no fatty change. We confirm with MRPDFF the percent fat is less than 5%, so it corresponds to no fatty change. This is a normal case. So the second one, this is an example of the my fatty change on B mode grayscale. You see the my fatty change compared with renal cortex. The bright score is 1. Consider my fatty change. So we do the ATI. ATI, you see the echogenicity is higher than the previous one, and measure out is cutoff 0.69. This is considered between S1 and S2. It's considered mild fatty liver. We confirm with the MRPDFF is my fatty change between 5 to 10% of fatty content percent inside the liver. So this one, how about this one? This is more significant fatty change. We can see the deeper tissue has obscure and not a good image inside because the liver attenuation is a lot. So we do the ATI. ATI has changed to be higher ATI value like this. So ATI is 1.1, which is more than S2. It's a very significant fatty change. So MRPDFF also correspond with the amount of fat inside. This one is around 20% fat infiltration inside. Significant fatty liver. So in conclusion, for the attenuation imaging is a technique or application equipped in ultrasound machines. It has a good moderate to good correlation with MRPDFF and can potentially use for grading and monitoring fatty liver. So before we move to use the shear wave elastography, we need to look at the basic. Shear wave is not the regular ultrasound beam that we use for imaging. Shear wave is considered low frequency wave that has a lateral propagation where they pass the medium. Let's say normal B mode, we use more than 1 megahertz to image the grayscale ultrasound. This is regular one. Shear wave is different. This is another set to use. Basically, shear wave is a low frequency sound. When they pass the tissue, they got tissue motion and got lateral shear wave propagation laterally when they pass the tissue. So the shear wave speed normally less than 10 meters per second. This is correlate well with the stiffness of the tissue they pass in the medium. Let's say this is the characteristic of the shear wave. Shear wave, when they pass through the medium, they got a lateral propagation as well, and then the sound beam go this way. For the longitudinal wave, which is like normally traditional B mode, since it is very high frequency, they propagate without lateral wave. This is a phantom image of a shear wave elastography and how they goes. Normally, when the machine goes, they have a push pulse of low frequency, and then they create the lateral propagation of the medium. Let's say there's a nodule here, and then where they pass, the one that have nodule is stiff, so the lateral wave or shear wave will propagate faster. This is the tissue property of the shear wave that we use to quantify the liver stiffness. So we apply like this. At first, the machine will have a push pulse, which is low or shear wave, and then create the lateral wave to detect the liver tissue or lesion. If the tissue is stiffer or harder, so the lateral shear wave will go faster. and then the elasticity corresponding to the shear wave is E equal to 3 log correspond to shear wave power of 2. That means if the velocity of the shear wave when they pass the medium is high, that means correspond to the stiffer tissue with the power of 2. So in clinical practice, we don't have to care much about the formula. We just measure it correctly and then interpret it. The first generation of shear wave elastography is transient elastography or fibroscan. Fibroscan has a practical view. We have just use the shear wave of 50 Hertz and then put into the intercostal area and measure the sound beam propagate into the liver. So you measure only 10 times and then calculate the medium, mean and medium stiffness. It's come at let's say 3.9, and then you just use the cutoff to interpret. In various liver pathology, they have different scale cutoff. Let's say hepatitis and hepatitis B and C is different cutoff. You just use the table and then use the cutoff, and then this will measure 3.9. You just draw the 3.9 line, so it's in the green area, so it's no fibrosis. Something easy like this. And how about shear wave elastography? Shear wave elastography, besides of have the measurement, we can see the grayscale underlying liver parenchyma if there's cirrhotic already, or the homogeneity of the liver as well. And we can select the area of measurement as well. This is considered better than transient elastography or fibroscan. So basically, the machine have the map that showing in the box that which one is the area is high or low stiffness, and also the good one is the propagation map. When we see the propagation map, we can select the good area to measure, because there's lots of artifact and measurement error if we do not see the propagation map. Let's see, there's a motion artifact that can influence the area of the stiffness, the color elastography. Let's say this area, maybe why is less stiffness, this area is high, right? But this one, if we see the propagation map, we use to select the area of the line parallel together. That means it's constant. We prefer this area to measure. And then we measure and then calculate the mean and median and IQR to report. As well as fibroscan. Elastography, there's a cutoff that we need to remember to use as a clinical practice. So basically, when we do the liver elastography, we would like to know when the patient got significant fibrosis and the cutoff for cirrhosis. There's two main things. The significant liver fibrosis is considered stage more than 2. If they have a stage more than 2, they can give the antiviral treatment to bring it down, can be reversed into like less severe fibrosis to prevent cirrhosis. And the other cutoff is the cutoff for cirrhosis. So hepatitis B and C have different cutoff because different liver pathology. Presuming that hepatitis C have more background of liver inflammations, while B is less. So it's basically, I need you to maybe use this cutoff. This is a meta-analysis suggested the cutoff. Hep B is around 8 to consider significant fibrosis, and cirrhosis is around 11.5. And if you see this cutoff, it's very high sensitivity, 94. However, the specificity is 73. That means if you use cutoff for significant fibrosis for hepatitis B, there's 1/4 of the patient has a false positive. That means 1/4 of the patient got falsely high elastography, and we maybe overtreat the patient. I will give you some example. Let's say if we have hepatitis B patients and have do the elastography and measure, let's say, more than 8, that's considered significant fibrosis. The thing that we need to do is reconfirm either by liver biopsy or MRE to make sure this is not the falsely high in order to eliminate the over treatment of the patients. So let's see. I have one case in the clinical practice. He's a 48-year-old male with chronic hepatitis B infection, and with a clinical trial for consider anti-HBV treatment if there is advanced fibrosis. So we do elastography. This is MRI baseline. MRI. There's no obvious cirrhosis yet in this case. Okay, we do a liver elastography. So it's come out at 11.9. Do you remember the cutoff? 11.5 is considered cirrhosis. So this is a high, very high elastography. So the thing that we haven't concluded yet, we have to reconfirm by MRE because of there's a specificity of the high elastography is 72%. So there's a 1/4 of the patient can get falsely high elastography. The patient undergo MRE. It's confirmed by the MRE that patient has also have significant fibrosis on MRE. More than 3 kilopascal is considered high for MRE. So this one is reconfirmed for advanced fibrosis. So patient got treatment. So in conclusions, today we talk about the 3 application add-on on ultrasound machine, which is SMI. SMI is have beneficial in order to see microvascular structures. We use in my experience, we use this information to detect a mass effect, to distinguish true and pseudo lesions, and for some of the vascular flow pattern can suggest specific lesion, including hemangioma and focal nodular hyperplasia. For ATI or attenuation imaging is a novel technique for liver fat quantification. It is potentially used for fatty liver grading and monitoring a fatty liver percentage after treatment or modification of lifestyle. For shear wave elastography, it is a non-invasive stiffness measurement of the liver. So it's a potential for look at the hepatic fibrosis staging and cirrhosis evaluation. So with this, I would like to thank everyone for attending my topic today, and also Canon Medical Asia for having me today. Thank you so much.